We are past the year. We've had our moment of reflection, and I do hope we can look forward to meeting in the flesh again sometime this year, although I think it may be a while yet. But at least quite a few things are looking more optimistic in terms of COVID at the moment. So, you know, it is a moment to pause, I think, again, and think about what the last year's been, and think about all the things we've got to do for the next year. But there's a lot of positives come out of it. Let's not lose the learning, because there's been a huge amount of that in the last year. And there are some things which are infinitely better than that. So, do I have any apologies for absence, George?
Not that I've heard. Is Helen in, though?
Yes, she is.
Oh, okay. No, I haven't been told of any.
Good morning, Helen, and good morning to anyone I haven't managed to say good morning to yet. I think that might be Jane Skinner with the...
I thought it was with the dashes.
I can't do anything about it. I'm sorry.
We will get you some help, Jane.
Thank you very much.
Okay, I apologize for absence. I don't have any then, George.
No.
Okay, thank you. And thinking of apologies for absence, it's a pleasure to have the governors connected. I know you've had a lot of trouble. Well, the YouTube option worked really well at the beginning. It did seem to be unstable and to leave you dropping in and out. So welcome back into the room. Declarations of interest. Do I have any additional declarations of interest on today's papers? I don't see any hands going up, so I'll take that as no. Questions from the public relating to matters on the agenda. I've got two. If you'll bear with me, I'll just read them. I'm proposing that Sue and other members of the executive, I think you can probably pick these up in your reports, but if you could make sure you do, and for Clive and Liz, who asked the questions, if you feel that you haven't had sufficient assurance, then come back to me and let me know. So one is, what assurance does the board have that the level of 75% of CQC musts, being blue, black, green, as stated in the improvement programme report summary, and that's on today's agenda at 13.4, is an acceptable level of progress? And is the focus for action on the correct areas? So I'm just going to turn to you as the lead for that programme board. Are you happy to encapsulate that in your report?
Yes, I am.
Thank you. And the other one, which refers back in many ways to my introductory remarks, the latest update from government indicates that we may go into wave 3 later in the year. Can we be assured that with all the ward movements, etc., and building repairs, we would be ready if needed to deal with such an increase? Helen, I think that principally falls into your report area. Please, could you pick that up in your report?
Will do, Sheila.
Thank you, Helen. And Craig, you may want to make some allusion to the building works and the estate works in yours, if you would.
Of course.
Okay, I have no other questions. Richard, you haven't had any late submissions, have you?
No, not at all.
Okay, thank you. Right, reviewing the agenda. Apart from it being a busy agenda, nobody's asked me to move anything around, so I will proceed as it is on the papers. Minutes of the previous meeting then, please. Can we turn to those when my machine catches up with me? My apologies, it's gone back to square one again. I will be with you shortly. Okay, I'm going to take it page by page. Please put your hand up if there's anything you want to raise. Page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Steve, was that a hand up?
Yeah, so I think page 19, Sheila. Let me just pull up
19 of convene.
19 of convene.
Yep. That's page 9 of the minutes, if you'll happen to be working.
It was regarding the capital planning limits, and it says it was not likely to affect West Suffolk. If I understand rightly, that is because we do not have, huge cash piles. It's not that it will curtail our freedoms. It's that we don't think it is likely to have a material impact on our planned expenditure because of the position that we're in financially. There are some, NHS trusts with extremely large, in a sense, reserves, and this will affect their ability to spend and renew their capital base. It's more about the position that we find ourselves in. So we probably just need to be just a little clearer on that in the revision to the minutes, if that's okay.
Okay, thank you, Steve. Can we agree those offline, please?
Yeah.
Thank you. Sue?
Yeah, sorry, Sheila, it was going a bit too quickly for me. Page 3 of the minutes, page 13 of convene, the top paragraph where we talk about the messages emphasised how vital the services are to many families. Where we've written the clinical helpline also enabled staff to be made to feel useful and contribute. I think, can we just take out the wording made to feel useful, because that sounds a little bit not quite right. I think it's enabled them to contribute and continue to work when they're self-isolating.
Yes, it's perhaps sloppy language, I would say.
Yes,
thank you, Sue. We'll alter that offline. Thank you very much indeed. Okay, no other questions on the minutes then. Can I sign those at a true record then, please? Right, action sheet, please. If we could turn to the action sheet. And if we go to the first page, they are all green and on course. So I'm not going to run through them one by one. Is there anybody who wants to raise anything from any of the items on page 28 of convene? That's the first page of the matters arising. I'm happy to take any comments, questions. Angus, you look as if you're heading for your machine.
God, that's impressive, Sheila.
I'm getting better.
Yeah, it's a small point on 1928. The way I read it is, I think that action's now closed, because the action was to schedule a briefing. It's been scheduled, therefore
Yes.
The action is closed.
Richard, you close that off?
Yeah, happy to do that.
Okay, that's excellent. I like ones that close. And I have Louisa.
Sheila, in respect of 1927, the provision for the keeping in touch for the community services, I know that we've got a date there of April. Is that a date when we'll have an update, or when we'll have some idea of the provision that we'll have moving forward?
Sue?
I'm sorry, I'm trying to juggle putting my hand up and unmuting. I think that, to be honest with you, Louisa, I think that's probably a slightly longer term project that we need to work with the community team. So I think you're correct in saying, is that a reasonable target date? And maybe we should extend the target date, because it's not going to be an overnight switch on, switch off type process.
Yeah, I think that's reasonable, so thank you.
Okay, if you could keep us posted on that, Sue, because I know it's a service that the board feels very strongly and warmly about.
Yes, so it's absolutely with, we need to make sure it's in our community hospital beds and also outside in the community services. So I'll work with the teams on that.
Okay, thank you, Sue. Alan.
I'd like to request that 1915, the first one, is left open, because my interpretation of the community metrics is that we haven't really cracked this yet in terms of recommending how we measure outcomes in the community. I know the team is looking at it. I don't sense, and when I read the report later, I didn't really see a change in that. And I'm wondering, I know it's going to take time and the team are already on it, but could we leave that open rather than green?
I wonder, Alan, whether we should check the action from today's meeting. This one is to recommend appropriate community effectiveness metrics.
It's work in progress. I'm very happy that it's work in progress. I just feel we're not really there yet, and so
I agree.
Is that fair, Sue?
Yeah.
So this I think this one's sits with me, Alan, not Sue. But if you recall, last month it had a deadline for this month, and what I said at the time was it wouldn't be complete by now. So we were going to move the date, and people asked for a progress update. So I agree with you, Alan. This is going to take some time to work through, and we will, in the community reports, provide progress updates as the group continues to work it through.
That's fine. Thank you very much.
So it's an ongoing one, rather than a stop one. Okay, that's fine. Any other issues here? Most of them seem self-explanatory and straightforward. Okay, thank you. If we can move then to the second sheet, and they are all complete, unless anybody wants to add anything to those, and I don't see any hands indicating, I'll take that they are complete and we can close them off. Okay, thank you. If then we could move to the Chief Exec's report. Steve, we've had the opportunity to read it. I know there will be some things you want to highlight.
Thank you, Sheila. Let me first just underscore the points you made around the moment of reflection. I just wanted to thank to all our staff and all the health and care staff across the west of Suffolk for being absolutely magnificent through a really challenging year since the first lockdown. People have been massively flexible, hugely professional, and very focused on serving our community. So big thank you. And we've all had to deal with loss and adversity. I said this in my message out to staff, but we've all either lost somebody who we care about, we've not seen people we care about, and it's been really, really tough for people. We can't get away from COVID at home or at work, and so I think it's just important to recognise that. We are on the way out of lockdown. I'm looking forward to playing tennis on Monday, and it's clear that the vaccination programme is making a massive difference. I think around 28 million nationally have had a first dose of the vaccine, and around 500,000 in Suffolk, and that's around 60% of our population. So that's a massive achievement. So just thank you to all the staff that have been working on that vaccination programme. We do have the staff survey, and we'll cover that in more detail, but there's clearly more that we need to do around making sure that staff feel safe to both speak up, and we need to get better at listening and learning, and we'll come on to that. Also, the papers in the board allude to the digital papers, the go live this last weekend, and we went live with both scanning for safety and in maternity services, and those developments will improve the quality and safety of our services. And a big thank you to all the teams that did an amazing job in a very smooth go live. So thank you for that. Our thoughts are turning to recovery, and there are, we'll discuss that at length in the board today, I'm sure. I just wanted to note the tensions that we have between having exhausted staff and wanting to give them a break, but also there are exhortations to reasonable demands from our public to make sure that we improve the access and start to address some of the backlogs that have been created. That will take time, and there are tensions there. The staff will want to take leave, and they'll want also to maybe get paid for that leave and help with the recovery effort. And we need to do that sensitively, and there's a real tension there, and we're trying to be very gentle and respect our staff on that. But I'm sure we'll have a strategic discussion around that. As ever, through the pandemic, though, our clinicians have been doing an amazing job, and not just focusing on the pandemic. And it's great that the radiology service has had 10 years of accreditation and managed to achieve that. We'll also probably say a little bit next month of our orthopaedic team, who have also delivered the best hip fracture care in the country. Once again, that is no mean feat during a pandemic. Staff have been really dedicated, not only in dealing with the pandemic, but also trying to maintain the high standards that we really appreciate. So that's pretty much all I wanted to say. I'll make that 3 minutes, Sheila. Oh, sorry, 4 minutes now. So hopefully relatively brief. Over to you. I think you're on mute,
Sheila.
Oh dear, I'm starting early today. One of the points I was going to make, the strength of your report is that it both gives us the West Suffolk view of the world, but also you always make an attempt to put it in the context of the wider NHS and social care. And that's really important because we are not an island. And I think it's times like during an epidemic, you are particularly conscious of that interdependence of different organisation and different sectors on each other. David, you had a question.
Yes, Steve. Just wanted to talk about vaccinations. The report says that we've achieved nearly 76% of staff vaccinations, and it notes obviously some haven't been able to have them for various reasons, and they will catch up. Just wondering where you anticipate we might finally end up, and I know we've written to people who we believe haven't had vaccinations, and whether there's anything more we can do to support those staff in helping them make that decision, given the importance of vaccination.
If it's okay, David, I'll bring in Nick, who's done a tremendous amount of work with the team on this, and it'd probably be better if Nick answers that, because he's taken us through as an exec team some of the detailed work that he's doing around that. But Nick deserves a lot of the credit, as does Joe Rayner, for the tremendous, with Tracy Oates, the tremendous programme that they've done on the staff vaccination. Nick, do you want to?
Thanks, Steve. I'll absolutely let my team take credit for the vaccinations that have been done, but I think David's question is more about the ones that haven't been done. So let me try and address that, David. There are principally, some people didn't have a vaccine because they couldn't, either because they were too soon after a infection with COVID, or because of some other condition such as pregnancy that meant a vaccine isn't appropriate for them. We have a trickle of those people being vaccinated in the organisation, so we will catch those ones up. The bigger group, though, is the ones who, for one reason or another, chose not to be vaccinated. And I think it would be fair, if it's all right with you, Sheila. I see Jeremy's got his hand up. So we've all been working on how to address those, and our public health team have been taking a keen interest with the comms team and Jeremy's team. But I think might be fairer to let Jeremy give the detail on that.
Jeremy.
Yeah, thank you, Nick. I think there were a mix of issues here. So, of course, there are a number of staff for whom they have decided that they don't wish to have the vaccine yet. That is a real issue. And as Nick says, we have reached out to those members of staff, both individually and certain groups of staff as well, to provide information and assurance and access to someone that can answer their questions. I think as well there is also a bit of a data issue. We've taken a very broad view in terms of the denominator for this percentage, so we've included all staff who are currently registered as bank staff with our organisation, and we think that may include a number of staff who haven't worked here for a very long time, but they remain registered on our bank. So we are doing some work just to validate that, but that may be affecting the overall percentage.
Okay, David, did you want to come back on anything?
No, it's just really to get assurance that, we are doing as much as we can to support people to help them make that decision, because obviously it's important for both staff and for patients.
Yeah. The thing I would add, David, I mean, I suspect everyone's probably aware of the debate that was happening earlier in the week about whether it should be mandatory, compulsory to vaccinate, care staff or health and care staff, and I'm sure that debate will rumble on, and we'll get clarity on that. So I think that debate is there. At the moment, it's personal choice, but we're strongly encouraging it and seeking to do everything that we can to reach those groups that maybe don't want to avail themselves of the vaccine for a variety of reasons.
I think I'm right from the information I've read so far and the evidence I've read so far. Persuasion seems to be the best possible way of achieving the end result. Okay, thank you for that. At which point I'll move over to Helen, please, for the operational report.
Thank you, Sheila. I will assume people have seen and read the report, so there's just a couple of bits that I'd pull out. The first one is to confirm, and some of you may have seen it reported yesterday, but yesterday officially Simon Stevens dropped the level from management of the NHS in the COVID pandemic from a level 4 incident to a level 3. That's great news in terms of the position we find ourselves in and the pressure on the NHS having been reduced. That still leaves us to some extent in a command and control structure, but it's at a regional level. And it's the way in which we all worked through the summer. So generally some good news on that one. In terms of COVID activity and the update, we are now seeing low levels of COVID admissions. They do continue, and therefore we do need to be incredibly vigilant. As it says here, at the time of writing, we had 2 COVID inpatients. We do today have 4, and we are seeing small numbers come through. I think the other important thing to say, and this is not just a West Suffolk picture, this is a picture that at least is reflected across the region from what I understand, and that's that non-COVID activity in the past 2 weeks has increased sharply. So we are back to seeing 200 or over 200 attendances in ED on a daily basis, which is considerably busier than the department was in the first wave. If I just move on to the section of the report talking about the fail-safe programme, we have now enacted the moves that are spoken about in the second paragraph. So F7 is now back to the point to address the question that was raised, because we have been able to do that as a result of the low level of COVID admissions. I think the person who asked the question was asking for assurance that could we do everything, and probably not is the answer, sadly. We are very connected to trying to understand what this next wave might look like, but at the moment there is no modelling to either give us any indication of numbers or when to expect it. So we will be vigilant and keyed into everything that we can in terms of trying to understand it. But in reality, managing the fail-safe programme and managing the organisation operationally is a constant balancing act. The operational teams and the estates teams work incredibly closely together, and we are managing the risk on an ongoing basis as we see it. So at the moment we have got the capacity and we're actually moving slightly faster. We're ahead of the game in terms of emptying capacity to start the fail-safe programme, and we will just have to flex and manage that as we go through the next few months. If I move on to the elective restoration, again, just to say to people, the final Planning guidance arrived in our inboxes at about 3:30 yesterday afternoon. So we will need a little bit of time to assess the detail. However, from what I've seen of it so far, it is in line with what I've laid out there in the paper, and looks to be in accordance with the plans that we have been making. There is a section there just talking about, a very short section on endoscopy recovery, and our first priority is obviously to recover the 2-week wait backlog, and I'm really pleased to say that's making significant progress. We're now seeing most of those patients at 3 weeks rather than 2. So we've got a little bit further to go, but I do expect by the time we meet next month that we'll be on track with that. That will have an impact on the 6-week diagnostic, but then there is further work to do and we continue to focus on that.
Helen, before you move to the next section, I've got some hands up, so could I take a couple of questions before you move on? Angus.
Thank you, Sheila. Thanks, Helen. I wondered if I could just ask a question about the Elective Restoration Plan. It was twofold. The first was, I just see this as so critical as we move forward, and I'd be grateful if I could just understand the governance around it and how we are really getting into the nuts and bolts of that. With that in mind as well, when I look at the appendix and some of the assumptions that are in the plan, it looks as if there's quite a step up between March and April, and then it just raised the question more generally about us being really clear on what are the core assumptions in this plan that, if they prove to be incorrect, could really knock us off, and how are we monitoring them, keeping on top of them as we move forward, which is sort of connected with my governance question.
Okay, so at a local level, every specialty has a recovery action plan that's monitored within the specialty and then is monitored at the weekly access meetings that I think some of the NEDs have joined. They are all in the process now of being refreshed, because obviously the plans and the numbers look slightly different, but we continue to focus on that. And Alex and I regularly join those to pull the threads together, and Hannah Knight is the head of elective access. So we manage that quite tightly internally, and then there are a number of system and regional meetings. There is an ICS-wide recovery action group and an elective recovery board. So there are a number of forums in which we manage it internally, and we also manage it across the ICS, because the move to manage these things as a system is much, much stronger and much clearer in the new planning guidance, and that is the way in which we've been working. In terms of assumptions, I think the activity level assumptions of what we can deliver, I am comfortable with. The things that may cause us a problem, so if the decamp programme comes up against unexpected issues, the theatre programme takes longer than we think, those kind of things, obviously that will impact upon us. The bed assumptions are, the one thing I can guarantee you with the bed assumptions is we've modelled a best case scenario and a worst case scenario, neither of which will actually be the reality of what happens, and we will manage in between. Now, our worst case scenario that gave us a very big bed gap gave us an 8% level of COVID and 100% level of non-elective. We were then advised to model 90% non-elective and 3% COVID. Those are educated guesses, and if we see more COVID, or if we get back to 100 or 100 plus of non-elective activity, that will impact on our bed capacity. And the thing that is really clear this time round is that if we are to maintain progress on the fail-safe programme, operationally we have nowhere to go in terms of additional capacity. We are working with system colleagues. We're doing a big piece of work, more of which will come in next month, around our length of stay. So we're doing work with ESIST, and we are talking to ACS and the CCG around what additional out of hospital capacity we can create. But those, you know, if anything keeps me awake at night, Angus, it's those assumptions and working through the reality. Does that answer your question?
Yeah, it does, Helen. And just a small observation on governance, and I don't know how to put this delicately. I get enormous reassurance from you and the team being all over this. It's just a question of whether we need a set of almost third party or set additional eyes within the organisation just to give you that fresh view.
So you've got the regional team and you've got the CCG. I'm not. So when, if I'm honest with you, we have in the past had the internal auditors, and they've looked at data quality and that kind of thing, but they're not experts. So
yeah, sorry, Helen, I'm not. That's not where I'm going. Where I'm going is almost your critical friend in the organisation who just says, "Helen, have you thought about?" It's not the regional piece. It's just trying to ensure we really keep and help you work through this, because I know what this is like.
Yeah, very happy. Perhaps we talk about who that might be, Angus, and who might want to do that. Very happy to do that, because this is a wicked problem. So the more people who want to join us and see whether we can refine the plan, I'm more than happy to talk to you about that and see what we could bring into the mix. The other thing I would say that is a challenge for us. And when you look at the appendix to the report, which, apologies, that was late, that information only came to us in the middle of this week, which is why it was submitted late. But I know you had asked last month about comparison with other regional organisations. We particularly compare ourselves with ESNEFT as we develop a system plan with ESNEFT. And I think the thing that challenges us locally is we have very limited options for independent sector capacity. And so the conversation we are having as a region, as an ICS, is there any way we in the west of Suffolk can access more of that independent sector capacity in the east? That sounds easy. And I'm sure you would all expect that patients, if they were told they could have their procedure sooner, would rush down the A12. Unfortunately, they don't. So if I could say to you, we have secured additional capacity near Ipswich for ophthalmology. My team phoned nearly 200 patients to get 50 of them to move.
Wow.
Now, we continue to do that. And we were offering transport, so you can see some of the challenges that we have. People develop a relationship with the organisation, and usually they want to stay there once they've done that. So we're talking about, can we redirect referrals, all sorts of things, but absolutely trying to access more capacity outside. So when you compare our levels of activity to ESNEFT, they have access to probably 300 procedures a month in their independent sector. We probably have 30. So it makes a big difference.
Helen, this is clearly a really important point, and I can see why you refer to it as something that keeps you awake at night, because it really is. And I suppose almost offhandedly, you know, I can remember saying at the beginning of the COVID epidemic, you know, the impact on the population who doesn't have COVID will be just as great. And you know, that's an ongoing. I think it would be worth having a conversation offline around whether there is any more external. It's critical friend. It's not a criticism in any way, shape or form. Is there any more capacity resource we can draw on to get another parallel view? In the meantime, I think my experience of working alongside the CCG, they are quite good at doing that, albeit they are part of the system. And so, you know, have some of the parochialism. Oh, I'm not saying they are parochial, but they have some of the local view that we have. And the same with region. I think, you know, because they have that regional wide view, they can be really valuable. So I think drawing on those is the immediacy. But if you would find it helpful to have one of the non-execs who takes a particular interest in recovery, that might be also a way of giving greater assurance to the board. And there's so much detail here, it's probably appropriate for that. So you and I can pick that up in our conversation next week.
More than happy, Sheila, and just to assure people now that we do properly have the planning guidance, it is our plan to bring a more detailed paper through to scrutiny. So we will be doing that in due course, but as I say, the guidance formally only landed yesterday.
Okay, thank you. I'm aware I've got some other questions. We need to move on. David and then Rosemary.
Yeah, hi Helen. It's clear you've got lots of balls to juggle at the moment, and the modelling is really, really helpful. So well done on putting that together. Couple of questions. The first one I think you've probably partially answered. It's really about elective patients, and in particular the period over the summer when we're going to struggle most with the theatres out. And it was really just to get some more assurance around, you know, or do we think we can get more third-party help on that particular period, which is obviously the critical one for us. And then a second question was really about balancing the need for staff to have some time to recover. And I'm just wondering what assumptions have been made in all of these models about staff recovery, and particularly, you know, people like the anaesthetists who've been under immense pressure.
Helen, so, briefly, because you've alluded to some of this in your report so far, what I know.
Yeah, we continue to work to try and secure any more independent sector that we can, David. But what we've got so far is getting to be the limits of our local capacity, including some insourcing by other teams coming in. So the next step is really to try and see can we get access to some of the independent capacity in the East, which I've talked about. And what I would say is some of our mitigations around extra sessions and changes to working practices have been developed bottom up by the teams in theatre and the anaesthetic teams, because we're very conscious of wanting them to own this. And whilst people are tired, there are a lot of people who also want to start to tackle this problem, and the fact that they're not getting through these patients is causing them as much anxiety. But we are working that bottom up to try and address that.
Okay, thank you. David, does that answer your question?
Yeah, it does.
I mean, there's more to explore, I recognise. Rosemary.
Thanks, Sheila. Good morning, Helen, and thank you for your report. You've partly answered my question when you were answering David's question, but I was just wondering how are you engaging with the medical community in terms of putting together that recovery planning? Because it's really crucial, isn't it, that there's buy-in from the organisation. I know you've got lots of lords and masters with the ICS and CCG, but what's really fundamental is that the medical community don't see it as an instruction, but they see it as something that they are a process they are participating in. So I just wondered if you could give me some reassurance on that, please, Helen.
So as I say, Rosie, these plans have been developed bottom up. And they are so far the plans that our teams feel they can deliver. I'm booked to go and talk to clinical directors and clinical leads around the planning guidance. And you'll see in the main, the plans that the teams have developed meet the requirements of the planning guidance. So what I'll be able to do now is go and say, OK, guys, there is a gap in first outpatients. is there anything else collectively we can do to close that gap? Because that's an area where we're going to not quite meet the requirements in the first instance. So it's a collective process, and it does start with the teams. And I'm not getting any sense that any of our teams don't want to engage in this process. They are desperate to get on and treat these patients.
Thanks, Helen. That's very reassuring.
Thank you. And Louisa.
Helen, brilliant report and a very assurance. The assurance you've given us is sort of tantamount to the work your team are doing. Just after Christmas, we saw a wave of do not attends, and I know this is a little bit operational, but it was starting to be a theme across all the specialisms, and people sort of saying, "I'll wait till after this wave." So, in terms of the work your team are doing, and maybe it's a question for Helen really, Helen Davis, around have we an associated comm strategy for our community to say, actually, do you know what, we're open for business and please come in for your appointments, because you're trying to maximise the efficiency and the capacity we've got. We just need them to sometimes do their part. So the question is, are we seeing that same level of do not attends? And even if we've got a few, can we what are we doing to actually fill that?
So if I could start, I'm sure Helen will come in on the comms, but we haven't been doing face-to-face outpatients other than clinically urgent. We are now starting to open that up and step that up. It is true, however, to say, and it's gone in cycles from, I don't want to come until this wave's finished. I don't want to come until I've had my first vaccine. I don't want to come until I've had my second vaccine. So there is, it is most certainly an issue. We have clinical conversations. We set up virtual clinics with consultants and specialist nurses to talk to those patients and try to encourage them to come in. But yes, it's a challenge. Hopefully, as the news around the wave drops, then we will start to see an improvement in that.
Thank you. Helen, if you're in the call, do you want to make any quick comment?
Yeah, sure. So I think we had a strategy before my time, but for when we kind of reopened following the last wave in the summer. So we can absolutely dig that out and have another look. And I think it's a really important point. Absolutely. So we can pick that up.
Okay, thank you. We'll leave that one with you, Helen. That's a very useful suggestion. Steve?
So I just wanted to lodge in the board's mind that the anaesthetic team has had some pressure, but let's not also forget how wonderful medicine as a whole, which really bore the brunt of much of the pandemic surge, has had it, because they had both significant sickness and significant demand through the pandemic. And just Rosie, your point, I think Helen's sort of emphasised this, but let me just underscore it. Many of our clinicians are really desperate to start to address the backlogs, and there is that tension there. But we do know certain staff groups and certain staff members are struggling, and that's one of the reasons why all the psychological support and the other support is going in, and we're trying to be gentle and ask people, what can teams do?
Yeah, I think it's a really important point, Steve, and I've been very reassured that both regionally and nationally I'm hearing the same message, the understanding that this isn't a blanket issue, that different groups of staff have experienced the COVID waves in different ways. And so the support needs to be appropriate to those groupings, not just a one size fits all.
Yeah,
so
Sheila, that when we were Joe Churchill last week, we had some time both with the clinical director for medicine and some of our respiratory consultants with Joe Churchill, and one of the things that we communicated to Joe was how tired staff were and the need for that to be reflected in the national context. But also, I think those consultants did convey their desire as well to make sure that patients are appropriately served and so forth. So it was a way that we were trying to communicate upwards the real pressures and the real hopes and fears that staff have to our local member of parliament, but also somebody who is in a junior health minister.
It was a powerful message because it wasn't just from us, Steve. It was from the clinicians themselves, direct to Jo, and I think she very much took away those key messages. So thank you for that. Right, Helen, was there anything else you wanted to say on your report?
So just very, very quickly, Sheila, in terms of the community update, you've got the detail there around the digital agenda, but just to advise the board that we did not recruit to the director post on Monday. I met yesterday with Kate and a lady called Georgia from ACS, and we're moving forward at pace now to an external advert for that post. And we're also talking about interim cover arrangements. So we still have that in hand, but that's just to tell people where we are.
I think you've been reading my agenda. I'd written on it timescale to recruitment and interim measures. So thank you. Could we have an update on that? Because I think we all see this progress in community as really urgent. Okay, thank you. And thank you for the benchmarking figures from across the east of England. I'm sure you found them interesting, although there is a huge range when you look across them, but I'm quite sure quite a lot of people have spent time analysing them. Alan?
Well, I think it's just important, Sheila, that range is really very dependent on people's circumstance at the moment. Absolutely. So, yeah.
Yeah. Alan?
Going back to the community, the green diagram, it's a question for Steve, really. When this person is appointed, should we think of them as completely line accountable for the whole of community services? They report to you. Will they be a member of our board in the sense of being able to question them on anything to do with that?
Yeah, sorry.
Good. And do you think our brief, ironically, will stray into the social care area, given that this is going to begin to blur, and this person will be managing 2 tribes, if you like? Will we begin to hear about what's happening on the social side as well?
Well, I would hope so. Alan, to be honest, I think this is a great appointment, a great joint appointment with the County Council. That will give us, it will be somebody who's on our board. They will also have, senior reporting into the County Council. This is a great opportunity for us to learn more deeply around some of the social care commissioning. And, there is much talk nationally about greater, health and care shall we say, integration and social care reform, but there's always been a lot of talk about that. But if things do move on that, this post gives us a real opportunity to progress on that agenda. So I think this is both, really, really exciting. I think we've got a lot to learn in the appointment of this post. It's critical we get the right person, and I think going out to an external appointment is probably the right thing to do. We need to make sure this is a strong appointment for the system.
Absolutely. I think we need somebody really, really innovative and imaginative in that post. And I'm sure the lines will blur, and I'm sure at times that blurring will create some tensions, because you're right, Alan, it's tribal. But actually, that's the way forward, and then we can achieve so much for people, never mind patients, I think, by working in this way. So I'm hugely enthusiastic. Right, on that note, I will move over to Sue and Helen to take us through the IQPR. Can I just ask one question? Could you just, in going through it, could you allude to SPC, please? Because I think we'd all like to return to it as soon as it's legitimate, because we recognise the strengths in that and the way it helps us focus on the right things. So that would be really helpful. And the other thing is just to say, any feedback on the visual differences, can you give me offline after the board, please? Okay.
Sheila, you're obviously sharing notes here, because actually the only comment that I was going to make, other than to open up for questions on my aspect, was that one of the consequences of the lowering of the threat level and the reduction of COVID is that Jo Rayner, who's done a fabulous job in our core resilience team, can now return to her day job, and we're therefore in a much better place to look at the return to SPC charts. I've been reassured by the information team that although we haven't reported them here because initially we felt they weren't that helpful, they have continued to maintain them. So I don't think there'll be an issue. The issue for me will be working with Jo on a new set of metrics that I think may be more helpful in the current circumstances. So we will work that through as well. But that was going to be my only comment, other than to ask if anybody had any questions.
Okay, thank you very much for that. Steve, you wanted to come in.
So just reinforce that Jo's done a great job, so we should call that out in the board, and I think that also gives us an opportunity to revisit the IQPR. One of the things that I think, David, through your trawling through of other board papers, one of the things that struck me is that it looks like other organisations have continued with some of something akin to our previous IQPR and so forth. So, there is a question and a debate that we've had at the board about how useful, in a sense, that comprehensive report would be in the context of, shall we say, the pandemic. But given we've had, several months of the pandemic, that's when SPC comes into its own, isn't it? Especially, so we can start to see as we move out of this position, we can look at both SPC and maybe returning to a more detailed IQPR. So that's something that I think we should look to.
Thank you, Angus.
It's just a small point, but I recall a conversation at the board on SPC where I got the impression that the SPC was being produced for the board, but it may not have been used in the organisation. And I'd hate the board to try and push for something that actually the organisation itself doesn't, use for insight. So, I mean, it's far be it for me to say this, but I think it's open to the exec team to say, look, the best thing for this organisation is, and this is how we'll make the most of it.
Really, Angus, thank you.
If I could pick that up, so I think it's not that the organisation doesn't want it. I think it's that what we've been struggling with is the capacity in the team, due to all the COVID reporting and everything else, to create the dashboards at a divisional and at a specialty level. So we've got these SPC charts at trust level. We now need to move them down into the organisation rather than saying it's not something we want to do. So that will be part of the work that Jo and Nikki and the information team can actively take forward, and we need that in order to really inform the new committee structures. So that's the direction of travel.
That's really helpful, Helen. Thank you.
Thank you, Angus. Right, Helen, you were open for questions. Were there any questions? I think we've probably covered most things fairly well. In which case, Sue, can I hand over to you, please?
Yes, thank you, Sheila. And similarly to Helen, I'll take the report as read. There were things that I just wanted to raise for that. You'll notice that although the actual number of falls fell in February, that's not shown through the per 1,000 bed days, and that's due to a reduced capacity within the organisation. So just to note that, and also to note that pressure ulcers are still increasing. We know that this is a national issue. It's not just within our own organisation, and we continue to work through our PISA process to make sure we've got a quality improvement process to see where we can improve our level of pressure ulcers, and we're working with the national team for that. The other thing to say is that complaints remain reasonably low at the moment. We have only had 4 around level of care delivery. I think, again, as I've previously mentioned at board, we should be aware that at the moment we have no visitors coming in. We don't have any people seeing their loved ones on the wards. I hope this won't increase when we do allow visitors back, but I am sort of cautious that we may see an increase once the visitors start coming back into the organisation next month. I'm happy to take any questions.
Thank you, Sue. Any questions for Sue? Thank you then for the explanations. I think the way the charts work with the explanations has really helped to mean that we're well prepared and informed before we come to the meeting. So it's been really helpful, Sue. Okay, I'm going to move on then to finance, please. Craig.
Thank you, Sheila. So I will take the report as read, but there are just a couple of things that I want to highlight that aren't detailed in the report. So our current position is that the organisation breaks even, and we continue to forecast that we will break even over the next 5 days. There is a huge amount of work that is going on in the background at the moment around the end of year position, and it's probably worth highlighting that the way the funding is working for this year, there's far more of our income that is coming from a greater distance than previously. So some of the local management of the financial position has been removed to a certain extent in this year. So our funding is coming directly from the Department of Health to a greater extent than it has in previous years. That dislocation does create a greater degree of uncertainty than a more local organisation of finances. So we are still working through, with the regional office in particular, some significant funding around, most notably, the non-NHS income. So the amount of money that organisations earn from outside of NHS contracts. So in particular, those are things like car parking and catering. Obviously, the situation we found ourselves in over the last 12 months has meant that those income streams have dropped significantly, and there is central funding to cover that, and we're working with the regional office around that. But even more significantly than that, and it has been referred to earlier in this meeting, is the issue around annual leave. We have seen a significant reduction this year in the amount of annual leave that people within the organisation have taken, for obvious reasons that everyone will be aware of, both the pressure that the organisation has been under, but also the way that you can use annual leave has changed somewhat over the past 12 months. That extra annual leave that people will be carrying over to next year creates an accounting entry. So effectively, we have paid people for that annual leave, but at the point at which they take that next year, it creates a cost associated with backfilling that space, and we need to recognise that in the accounts. This is not an issue that's peculiar to West Suffolk, and it's one that is being handled at a Department of Health level, and so we are still working through that. That is a number of millions of pounds in the case of the organisation. And as usual with the finances do tell a story as to what's going on in the organisation. And so when Steve talked about the tension between staff being tired and the need to recover, that's reflected in the financial position. So people are tired partly because they haven't taken the annual leave, haven't been able to take the annual leave that they would have done in a normal year. The capital position in the organisation is of note this year. So we have a significant capital programme, and our ability to progress with that capital programme has been constrained by the situation we face. And so as we speak, there is an awful lot of activity within the organisation to try and make sure that we spend as much of the capital allocation as possible. If we don't spend the capital allocation we've been given, we will lose it, and therefore there is a real incentive on us to manage our spend over the next few days. One of the questions at the start from governors was around the structural remediation programme. That obviously features in the capital programme both for this year and for next year, illustrated, I think, most notably by the progress we're making towards gaining a decant ward. So that has started in this financial year and will complete in the next few months, so the first few months of the next financial year. But as Helen alluded to in her report, there is a degree of uncertainty around the remediation programme, so we still continue on probably a weekly basis to get more information about the structure that we're working with, both in terms of issues that occur within our main hospital building, but also things that happen at other organisations. That extra information does inform our response, and so it does mean that things change. That's particularly difficult for operational colleagues. We talked about some of the plans for next year, and those plans are contingent upon a certain understanding of the remediation programme. And when that remediation programme does necessarily change, that has very real consequences for the capacity of the organisation. And we discussed that far more at Scrutiny Committee. And just a quick word in terms of next year. So the board have agreed the provisional plan that we will enter next year with, cognizant of the fact that there were a number of underpinning assumptions that are significant and are, again, well, actually, as we speak, my deputy is on a national call to get some more information about the assumptions that we met, or the way in which finances will be managed next year. We have recently received confirmation that the way in which funding has occurred in this financial year will carry on for the first half of the next financial year, so up to the end of September. And as yet, a decision hasn't been made about the second half of the year. That will obviously be contingent upon the way the pandemic progresses. And finally, there is work that is happening within the organisation around the cost improvement plan for next year. Again, there is a degree of uncertainty around that, but there is a lot of work that's happening in the background. We made an assumption about the level of cost improvement that we would deliver in the next financial year, and we're drawing up plans in line with that assumption. But those are some of the things that aren't in the finance report, but I'm happy to take questions on in the paper. You're on mute, Sheila.
Twice. Meeting. I've got two people waiting with questions, Alan and David.
Okay, I've got an alliance that's on this morning. Building on the community question I had earlier, with the new director in place, will you be planning to delegate budgetary authority to them? And how flexible is that? Will they be thinking about pooling a budget with social care? And where's that going, do you think, in the next year or two? I know we're not there yet. I see this as an increasing challenge. So how loose are you going to be with the purse strings with this new director?
I'm never loose with purse strings, Alan. We've worked together for long enough that I'd hope you'd realise that. However, the question is a really good one and highlights the increasing recognition of the interrelationship between expenditure in health and social care. So the impact that we both have on other organisations and other organisations have on us is significant. Usually that comes out in the operational report in terms of challenges around our capacity, but that obviously has a financial consequence. So they will, in terms of financial governance, they will take over the responsibility that effectively Kate has at the moment in terms of managing the community side and being accountable for the budget. I would genuinely hope that we do get a lot more visibility about the financial flows in both health and social care. So I think your question earlier to Steve around the discussion that we will have at this board, I hope it will be richer because of that appointment, and I hope it will also include some of the financial relationships between the two sectors. So there are no plans to formally pool budgets, but I wouldn't be surprised if there does come a point where we're having discussions about a more broader financial landscape than just the health one that we traditionally look at.
Oh, yeah. So just to clarify then, the plan for the year ahead is sort of like our community budget for this year, but then that may begin to transition beyond that.
Yes.
Craig, in that context, the ICSs moving to a statutory footing and the concept of a budget across an ICS area, does that have implications for the way we manage those kind of posts, particularly moving forward?
Yes, I think it does. I think we already have good discussions and good relationships across the NHS from within the finance community. We already discuss the financial position in all of the organisations, and to a certain extent at an ICS level we aggregate those and we discuss what the overall ICS financial performance is. So that move away from a focus purely on the organisational is something that I think we've already got in train. I think it will be given a degree more momentum through the white paper and the statutory footing of the ICS, but there is always going to be that tension, and until there is some sort of definitive structural change, but organisations are still accountable for their own financial performance, while being mindful of the position across the ICS. You could see that in time that emphasis gets reversed and it becomes the ICS that's important while being mindful of the local expenditure position. So I could see that emphasis shifting, but it hasn't quite done it yet.
Okay, we'll watch this space. We could discuss this for longer, but I won't. David and then Rosemary, please.
Yeah, a comment on a question just on the Cip programme, which Craig referred to. You remember at the last board meeting I undertook to talk to John Connolly. It was in the PMO office, and I got an update from him yesterday. So just again, from a NED point of view, to reassure, I can see there's a lot of work going on Cip. An agreement now has been reached to embed within the divisions responsibility for Cip. So it's clear that there's progress on that, which is great news. Just on a question, in terms of, there's obviously still uncertainty about finances for next year, but we've now had planning guidance, and we've got approval for capital for the rack plank issue. Have we got assurance that any activity impact coming from the rack plank work and the building issues that we've got will not in any way impact our revenue?
So I think that's one of the areas of uncertainty, David. So we do have a plan that we've put together that has both an operational aspect but also a financial aspect, and to the extent that that plan gets delivered, then it's consistent with our financial planning assumptions. I think the problem is the uncertainty, and were anything to change around the RAC Plank programme, that will have consequences in terms of activity and our ability to recover effectively, and there are financial costs. So I think the assumptions that we've made are reasonable. However, our financial position is contingent upon those assumptions, and even though those assumptions I believe are reasonable, they are just that, assumptions, and are therefore subject to change.
Thank you. Rosemary and then Helen.
Thanks, Sheila. Good morning, Craig. I just had a question about the CIP plan, and I know you've done lots of work and David has around all of that, but really it was about reassurance on sort of timing. As we go into the new financial year, are we actually on track with the CIP plan, or are we building up a deficit for later in the year that we need to compensate for?
So the CIP assumption that we built into the plan was 1% over the whole of the financial year. That's significantly less than we've had in previous financial years. Yeah. The implicit recognition there was that for the first half of the year, our ability to deliver a cost improvement programme will be impaired. So a 2% improvement for the second half of the year is financially equivalent to 1% across the whole year. So that's broadly what we are aiming at. So a recognition that we don't go into month one of the financial year with a fully formed cost improvement programme that will deliver from that point.
Exactly. Thanks, Craig. I thought that would be the case, but I just wanted to check. Thank you.
Thank you.
Right. Thank you. And Helen, you get the last word, I think, other than Craig.
I just wanted to come in on the point around if the RAC Plank impacts our activity, and just to provide a little bit more assurance. So at the regional conversations that we are having around ICS restoration issue on a regular basis, I talk to the relevant director within the regional team, Adam Cayley, and I'm assured that the regional team are escalating this issue, not just for West Suffolk, but for the other RAC Plank hospitals, to the national team to try. There is no certainty yet, but there is quite a lot of lobbying going on. And the other thing, as I've said, neither Craig and I have had a lot of time to look at the guidance that's come out, but one of the things I did spot in there yesterday when I had a quick look is that there is an assurance written in the guidance that suggests certainly in the first half of the year, underperformance, if you term it like that, against the baseline levels of activity won't result in a reduction in income. What it looks like in the second half, none of us are clear about, but in the first, they've given that assurance.
Thank you, Helen. That's really helpful. I have no more questions. Craig, was there anything else you wanted to add before we close? In which case, thank you for your report, Craig, and thank you for the additional detail. We are running slightly behind, but we have got a 10-minute break. I'm going to plead with you. Can we cut it to 5, just over 5? Because that way we can catch up on time, and we've got a very long day. So 5-minute break, just time enough to make your coffee and come back. Okay, thank you. case, I hope you're fortified with even looking after our people. And on that note, I will move to Jeremy and the people report. Jeremy.
Thank you, Sheila. I'm really pleased to be joined today for my agenda item by Emily Baker, who is our head of clinical psychology, and you have a paper in the pack that we'll get to shortly in relation to our staff psychology service and what has been achieved through that over the course of the last 12 months, and also as we look forward what the future of that service might be. But before we get to that, I'll cover a couple of other issues from my paper and then bring Emily in. Firstly, as ever, want to celebrate the contribution of our Putting You First winners for March. They're in my paper, Trish Bivins, Marion Nunn and Jane Dallas, and you've got many examples there in those nominations that represent, you know, the often unsung ways in which people go the extra mile within our organisation to support colleagues, to support patients and their families, and to develop our services. Huge thanks from us as a board to those individuals. A moment of appreciation for them. And I'd also like to personally thank our day surgery unit and our anaesthetic team. I've received care from them over the course of the last week or so, which has been a great experience and a very grateful patient here of West Suffolk. So thank you to them from me. You have a further vaccination programme in my paper, which was a board action from last time. The data shows a proportionate take-up of the vaccine amongst our Black and minority ethnic workforce compared to the wider population. So that is assuring. But of course, as we will do, we will continue to monitor that and make sure that that remains the case. We have our next meeting of our BAME staff network next week, which I and others will be joining. So we continue to support the particular needs of our BAME colleagues in different ways. My report also includes an update on the staff survey. This is the latest results of the national annual staff survey that takes place in the NHS. Members of the board will have received a presentation from me in various ways over the course of the last couple of weeks. This is very much the beginning rather than the end of the analysis of these results, and more importantly, what we're doing with them. There is lots to do with our staff and with staff representatives to further develop our people plan in response to the West Suffolk has done really well in the staff survey. We've seen a year-on-year increase in our staff survey scores, which saw a real peak in 2019. But there's been a reduction in scores in our latest staff survey results from the survey which took place in October and November. So between that period of time, between the two main waves of the pandemic, and the paper details some of the ways in which those scores have reduced. In some cases by a small amount, in other cases by a more notable amount. We are very clear around where our priorities lie. We can see in the data where we need to prioritise our actions. As Steve has already referenced in his presentation earlier, there is a theme around what is called safety culture within the staff survey, which relates to the extent to which staff feel confident to raise a concern or feel assured that the organisation is doing something with what they tell us. So there is clearly more to do in that domain. There are some other areas where we've seen a reduction where we think that some of the things that we've already done during the pandemic to improve communication and to improve staff support and well-being might be the right, might help to address the concerns in the survey, but we won't take any sort of preemptive assurance from that. We'll talk to staff about it and make sure their views are incorporated in how we enhance our people plan. You've got some updates in my report as well around improvements to recruitment processes in relation to the wellbeing guardian role that is now a statutory feature of NHS organisations. An update on the annual gender pay gap report. One of the particular features of that relates to what is called bonus pay, which is one of the national ways in which all employers need to report. For us, that relates predominantly to the Clinical Excellence Award scheme that is operated in the NHS and the historical legacy of how that has operated. I suppose the pleasing thing in relation to that for 2020 is that all eligible consultants benefited from that scheme during 2020. That may well be reflected in how we analyse the data this time next year. You also have a separate report, which is one of our regular reports detailing all the activity in the organisation in relation to education and library services, and a welcome to Mr. Krishna Patel, who was appointed to a general surgery position earlier this month. I suggest that we move on to the presentation around psychology services and then take all questions in relation to my report at the end, if that's okay, Sheila. And as I say in the report, it has been this week sobering to mark the milestone, the annual milestone of the start of the pandemic and start of the first lockdown in the UK. But there are positive things that have emerged from a crisis, the improvements in how we support the psychological well-being of our staff was something even before COVID came along that was being worked on, particularly driven by Emily, Paul Molyneux, our Deputy Medical Director, and Denise, one of my deputies. And those plans were really accelerated and enhanced through the threat of the pandemic. And Emily's report is there, and I'm going to bring her in now. And I know Emily wants to share some anecdotes with you, some examples of how the service has supported staff, and to say a few words about how we might as an organisation develop that service going forward. So Emily.
Thank you, Jeremy. I'm sure you'll probably all have lots of questions for us, but before we do that, I just want to give you a flavour of what we've been doing and what a week looks like in the typical life of a member of the staff support psychology team. Between us, we see between 60 and 70 individuals a week. We run 2 to 3 sessions for whole teams a week. We run 1 to 2 teaching slots for groups of staff a week. One of those is the Wellbeing Wednesday that is broadcast, is accessible to all staff. We attend handovers at about 5 separate sets of handovers a week, just to make sure that we've got a presence at some of the most affected areas of the hospital. We're up to about 580 individual members of staff that we've seen across the organisation, and 146 different teams that we've supported. During the time that we've been running, we've supported 3 members of staff who have been the victim of sexual assault or rape, 3 who've been bereaved by suicide, and 3 members of staff who have attempted to take their own lives, and we've been able to work jointly with them and our colleagues in the psychiatric liaison team to link them in to the most appropriate services for them with that level of risk and distress. I just wanted to take the opportunity to give you 3 examples. One of somebody we worked with who, for a purely COVID related reason, one with a purely non-COVID related reason, and one that was a bit of a mix of both things. So my first person I want to talk to you about is a member of staff who is a ward-based member of staff who, at the beginning of the pandemic, before we had access to testing and before we had access to all the PPE that, you know, has come online after that, had moved into the residences in order to protect her parents who were shielding, and had developed symptoms of, well, was finding it very difficult to breathe and feeling very overwhelmed and very anxious, and phoned 111 and was told that it was definitely a panic attack that she was having, that was clearly what was happening. She tried to make an appointment with her GP, but the GPs weren't seeing people at that point. She tried phoning 999 because she was finding it increasingly difficult to breathe, but again was told very categorically that nobody would come to see her because she was having a panic attack. She contacted the team via Medic Bleep to get hold of us, and was feeling that she was being left to die. She just felt entirely overwhelmed and very distressed, but was being reassured it was a panic attack. And so therefore I met her in the car park of outside the residences, and we did a socially distanced psychological first aid session, doing mindfulness, grounding techniques, relaxation, that kind of thing, just to kind of to keep her safe. And we continued needing to do that during the couple of weeks that she was experiencing those symptoms until she was back at work. Later on down the line, it turned out that she did actually have COVID. The antibody tests came back, and it had been COVID that she was experiencing. It probably was COVID plus panic, but she was incredibly grateful for being able to access something on site that could come out to her, that was responsive, and that she felt being able to see somebody face to face safely. You know, we were walking a long distance apart across the heath, but made all the difference to her. And she still drops in occasionally to bring us flowers and chocolates and things to say thank you. She's very kind, but is one of our real success stories of the support that we were able to provide. My non-COVID example is a member of staff who was involved in an incident where there needed to be an investigation. And they felt absolutely, following the first meeting that they had following this investigation, they were left feeling that everyone would know what had happened, that they felt really ashamed. They felt that there would be reputational damage. And although they knew the policy was that people couldn't contact them to kind of check in on how they were doing whilst an investigation took place, they couldn't talk about the investigation, they were feeling that everyone would be better off if they were dead. That would be easier. They were feeling so overwhelmed by that, that system, the process, that they were really in quite a state. And again, we were able to meet with them immediately following the meeting that they had, the investigation meeting. Senior member of their team had walked them round to the office where we do drop in, and we were able to meet with them then and continue to meet with them regularly through the investigation process so that they had support. Probably the most powerful thing we were able to do is link them back in with people who weren't involved within their department, so they could get peer support and not to talk about the thing that they were being investigated for, but be linked back in with their colleagues, because obviously during a pandemic they weren't even able to see friends. They weren't seeing anybody. And so again, we didn't have very many appointments with that person, but we were able to safety plan with them and support them and link them in with the right support within their department, which, had we been an external organisation, there is no way we would have known how to do that. So being able to support them through that process was really helpful, and they're back in work, and it wasn't the catastrophic outcome that they were anticipating it might have been. It really wasn't as bad as they thought it was, but at the time they couldn't see that because they'd never been involved in anything like this before, and it just was very frightening for them. And the third person is somebody who had lots of care responsibilities for their parents prior to the pandemic, but then were redeployed into ITU and felt that they couldn't continue to provide that care, so they had their siblings providing the care instead, but they live a bit more remote. And then unfortunately, whilst they were working in ITU, their father was admitted to hospital and died, not of COVID, but of something entirely different. And that sense of guilt of not being able to provide care for their relative during that time was really very intense for them. She went on to develop COVID herself and had some long COVID symptoms, which left her finding it very difficult to concentrate, and was really worried, thought she was just going a bit mad, really. And we were able to continue to work with her regularly throughout that period. And she had a pre-existing difficult relationship with her manager, and so didn't feel she could talk to her manager very easily. So we were able to support that process and get her back with a phased return, and she's now back at work full time, and in fact volunteered to be redeployed back to ITU because she felt that she hadn't done her full stint last time round, and had volunteered to go back to ITU this time round and completed her stint in ITU very successfully. So again, it just gives you a flavour of the kinds of work that we've been able to do with people across the pandemic, and I hope that makes the report a bit more real for you. So that was, they were the bits I wanted to kind of raise with you before taking questions.
Emily, thank you so much. The power of the real story, and it just brings it alive. I mean, your report is fascinating and the details and the numbers, but actually that's about people. And that, I think, is what we all feel was most needed, and needed before, but even more so. It brought it into such sharp relief during the epidemic. And I know you and the team have absolutely worked your socks off to deliver the maximum you can, whether it be in the car park or inside a building or wherever or remotely. And I've talked to one or two members of staff, who have really expressed just how wonderful knowing the service is there, even if they haven't accessed it, they've got that sense that there is support there if they need it. And that's really empowering, I think, for people, even as I say, they haven't accessed it themselves. So I'm going to open it up for questions. Can we keep the questions on Emily's section for the moment? And we'll then briefly touch on Jeremy's other papers at the end, okay? David.
Yeah, I've got a question for each. So Emily, fantastic work that you're doing, and it's great to be providing that support to staff. To some extent, it depends on people coming forward to ask for help. And I think we probably know that not everybody feels able to do that sometimes. And I'm just wondering how we try and make sure we reach those people, from your perspective, what can be done to help people that don't actually feel they can come forward when actually they do need some help.
So we've had lots of people where colleagues have come with them to appointments, have kind of walked them around the corner, and we've done things where we've done it jointly with somebody they feel that they can trust in the department. That's worked quite well. Once they feel comfortable with us, they do tend to come back on their own, but the first time they might come bringing somebody else. We're also doing the React training for managers to try and, together with Denise Pora and some other people within her team, to train managers to have these conversations with their staff, and making sure that everyone feels confident and empowered to do that, so that hopefully that way they can have be signposted in that direction. And also by running wellbeing sessions on Wednesday afternoons that people can log on to, nobody knows who's attended those. You can get access to the support and information, and we've put as much as we can on the intranet site about all the different options that people have available to them, because it's not just our service, it's, there's lots of other ways of people accessing help, and one size doesn't fit all, so people need some choice in where they go. So that,
yeah, thank you.
Thank you. Richard.
Thank you, Emily. Superb apparent is that you're doing a huge amount of work. You've uncovered a huge amount of unmet need, and you've become a sort of victim of your own success to a certain extent. So 2 questions ready. One is about your team and how they're coping, both in terms of simple capacity, but also in terms of the support you're getting, because you've had to deal with a load of very tough stuff over the past few months. And the second question is, this seems to me to be just so important. My understanding is that there's a risk that this service won't persist beyond COVID. So what are the plans to embed this into what we do at the West Suffolk?
Okay. So it's starting with what we do to support each other as a team and what support we've got in place. All psychologists and therapists have to have regular individual supervision ourselves to keep, that no matter whether it's pandemic related or anything else, if you work in this line, you're always dealing with other people's distress, whether that's of patients or staff, or it doesn't really matter. And so we've got that embedded. All of us have got individual support. We have a team huddle every morning to check in with each other, and we check out with each other at the end of the day. We have a team meeting once a week where we all get to come together and support each other and discuss any tricky cases. We also have something called a kind of reflective practice session that we run for ourselves, where we make sure a care space, it gets called, where you take time to talk about what you're proudest this week, what your main challenge is and what's preoccupying your headspace this week, and then things you're looking forward to in the future, as a kind of just a very quick care space thing that we do regularly. So we've got lots of support in place for us, and actually developing a peer support network. So I have a colleague who does the same job as me at the QE King's Lynn, and she and I talk regularly about the challenges that we face delivering this kind of service, and that's also really, really helpful. And my professional network has, since the beginning of the pandemic, has had excellent resources being shared, and there's a few of us that contact each other regularly just to check in how we're going. So I think we've got the right things in place to provide that kind of support with the impact that the work has on all of us, really. And then in terms of how we embed what we've been doing and how we take it forward to be truly transformational, really, I think it would be brilliant to embed this within each of the divisions, so that people had support within each of the divisions of a psychologist, sort of fairly senior, to support the ADO and the triumvirate in each division to make decisions, to think about the mental and physical health of the patients that are under the care of that division, but also make sure that we're meeting the needs of the staff. We would obviously need to keep a subsection of staff support separate to that, so that if you didn't want to be seen by the person you also share cases with during your time, you could go elsewhere. And not every member of staff is within a clinical division. And so those people who are outside of the clinical divisions would need access to a ongoing staff support team.
Thank you. Steve, do you want me to bring you in now, or would you rather wait to the end?
I'm happy with either, Sheila.
I'll hold you till later then, if I may, because I suspect you'll like a last word.
No, not especially.
Rosemary, and then Angus, please, and then Craig.
Thanks, Sheila. And thank you, Emily, to you and your team for the fantastic work that you're doing. It really is superb. I've just got a couple of questions, a small one and a slightly bigger one. Firstly, I just wondered how you and your team engage with occupational health to make sure there's a consistency of approach and no overlap and so on, so that you're as effective as you can be. And then secondly, I was just wondering, as lockdown users, will you be adapting and adjusting your team to sort of support the community health team? Because I guess, I don't know, but their needs will be slightly different to those of the people in the trust. They'll have faced different pressures and they may need different sorts of support.
Okay, so with regards to occupational health, Sue Pollitt, who's the head of occupational health, comes to the workforce meeting that Jeremy chairs every Thursday that I also attend. So we meet regularly through that forum to raise any issues. We also have, throughout the pandemic, we've been signposting people to her and she's been signposting people to us. And so we've had a really good dialogue between the two teams to make sure that we're supporting each other and are very aware of what the other team provide and don't. That's been one of the best things really during the pandemic, is meeting all the other, even virtually, meeting all the other people who are also working with wellbeing, or looking after wellbeing across the trust. There's so many people involved, and that you can end up with duplication of effort, which is not helpful. So, but knowing who's able to provide what has been really helpful, and knowing there's like a network of support of interested champions of wellbeing across the organisation is really helpful. And then from a community point of view, so you mean community outside of our community employees? You mean more the ICS more broadly, do you?
No, I mean actually our own employees that work out in the community doing community health roles, as opposed to actually in the trust.
Okay, so all of the with the community, we've tried a variety of different ways of engaging with community staff. When we ran drop-ins at the community sites, nobody used them, because their work is so unpredictable in the community that unless you had enough staff to be permanently stationed in all of the bases, and they were also being encouraged not to work from their bases where possible, to do as much as they could from their cars or from home. And so finding a way of being where they're at has been a challenge. So we've got round that by joining their team meetings and doing team sessions rather than individuals. And then after that, people then know how to make use of it. We're doing lots of virtual consultations with people over Teams or via the telephone. So we've worked quite hard at engaging community staff, and we've had team visits to some of the community bases to do team sessions face to face where that's been appropriate, even if that was standing outside after a very, to do something in the kind of under a gazebo or something, in order to make that work for people. So we've done all sorts of different ways to try and engage with them. And yes, once we're fully staffed in May, when our final members of the team arrive, we hope to be able to do a bit more of that proactive stuff around the area. Yeah.
Great, thank you. Well done, Emily.
Thank you, Emily. I've got Angus and then Craig.
Thanks, Sheila. I'm going to lay my cards on the table. I'm going to ask Steve a question. So my cards on the table is, I just think this is a stunning achievement, and it's fundamental to our future as an organisation. The paper itself presents a coherent business case as far as I'm concerned. I guess the question for Steve is, how do we weave this into our fabric going forward?
Steve, I'll bring you in at that point, and I think we may want to bring Craig in as well at that point.
Well, so we're absolutely, Emily's done a fantastic job. The team's done a fantastic job, and really appreciate, Emily, your leadership around this, and those staff stories. Incredibly powerful in terms of how people have experienced it. Absolutely, Angus, we are committed to this service. I mean, Jeremy's paper highlights how we have dipped in some of the scores on supporting staff in terms of health and well-being. I think many of the things that we've been doing in response to what matters to you and so forth really is about trying to up our offer. And one of the things that I think we will learn from this pandemic, and I've just written a blog for the NHS Assembly actually, which I should make sure the board and the governors and colleagues see, which in essence ask the question, why is it taking a pandemic to really up our game in terms of support for staff? I think we have had that focus historically at West Suffolk. That underpins why we've had strong staff survey results, but there is clearly an unmet need that Richard alluded to, and this service is really helping us with that. One of the questions I had a little bit for Emily is, once we've moved out of providing that crisis support, what other, in a sense, more general positive support can we do across the organisation, and would the team have any thoughts and ideas on that? There is something about also linking to Jeremy's, I think, excellent overview of the staff survey, which is, how do we create, in a sense, the confidence of our staff to speak up and create more additional psychological safety. So I think it's probably appropriate to ask a psychologist how you could help with that. And the other question that I had in my mind was certainly from the first staff survey, there were clearly issues around how we could talk around an investigation. Now, we're all aware that that was also an issue that was raised in the matters that are under the purview of the external review and so forth. And I suppose there is a question in my mind, and I know this is a tricky line to walk and to balance, which is how do we communicate around investigations when they are confidential, but that's also a source of staff anxiety when they are party to that. So there's strong support, Angus. You have our commitment, and I'm sure Craig will reinforce that around this. There's something about whether we want to expand it. There's something about how we create additional psychological safety and how we support around investigations, and whether there's anything more that we can do to enhance the support that we give to our staff in those contexts.
Thanks, Steve. Craig.
Thanks, Sheila. My camera's stopped working, so I apologise. I think that you can't see me. I agree with Angus. I think effectively this is a business case. When we had the discussions with Emily some time ago, it was important to stress the need to be able to measure the effectiveness of the service, and that's something that Emily's been doing all the way through, and you can see that illustrated in the paper. One of the things, and it hasn't been mentioned so far, and I just wanted to pull this out, is that Emily's talked about the support to individuals that have needed her help and her team's help, but the way it's been done, I think it's helped a number of other people across the organisation as well. One of the things that came out most notably from the What Matters to You survey was the importance of good line managers. And I think the way Emily and her team have approached the implementation of the service is to not only support the individuals, but support the managers of those individuals, and is making them better managers. And I speak personally from that, having to deal with things which you haven't experienced before, and not knowing the right way to deal with those things. Having Emily there in the background has been a huge support. So I think this has impact on so many levels, and I agree with Angus. This is probably one of the strongest business cases we will have seen.
Thank you, Craig. And Nick, I'm going to bring you in before I try and draw these threads together.
Thanks, Sheila. I just wanted to really highlight how the support that Emily and her team give to staff is exactly as Craig's just alluded to, a real support for line managers as well. I had a difficult conversation with a member of staff this week where essentially I was presenting them with a series of allegations that I knew they wouldn't want to hear, and always would offer signposts to well-being at the end of that conversation, but they sometimes historically felt a little empty, or at least remote. You can bring the 24-hour support line that is available to all staff. You can talk to Occupational Health. You can talk to your GP. Now, actually, to be able to add, and you can talk to our staff psychology support team. And I don't think this person will, but I know that some people who I've had these kind of conversations with have. And I think it's a real added benefit to the people on the other end of those conversations, on the not on the receiving end of those conversations. I think that's good for our well-being too.
Oh, Nick, I think you've disappeared. Emily, you're still with us, Emily, anyway?
I am, yes. I just wanted to come back to Steve's point about the kind of the way forward and the kind of work that we would be looking to do beyond that. And I think actually if we could embed support at the start of any investigation for that person who's off whilst the investigation takes place, that would be really useful. I think there's lots to do around empowering managers, around having difficult conversations with people and supporting them through that. Some of the HR teams who deal with some of those things have also reached out for support for themselves as teams about training and with those kinds of things. There's so much that could be done, and actually a lot of the time it's the mental health of the patients in front of them that is impacting negatively on the staff. So actually being embedded within the division so you can flexibly respond to the need of patients and the needs of staff in the model that the ICS has used for embedding psychology within ITU, I think would be quite a useful potential way forward. So I do think there's a lot that could be done, that it could be I think it's a really positive opportunity for us as a trust. We really have pushed the message that it's okay to not be okay, that it's not stigmatizing, that this is a normal response to an abnormal situation, and that breaks lots of the taboos around accessing support. And it isn't you're being sent to see the psychologist, it's you're going to go and have a conversation with Emily or with Dan or with Pete or with any of the other people that people have come across within the organisation, and that just makes it easier. You're having a conversation with a colleague rather than having a conversation with an external organisation, particularly one with the words mental health in their title.
And as we learn more about the impact of certain processes on individuals, so we've used the word investigations several times in this conversation, what we've learned is that actually if you change the emphasis, if you talk about learning reviews as opposed to investigations, the purpose of the investigation, which is about learning, much more apparent and less around something that feels community.
Yeah. Thank you, Jeremy. I've got Helen Davis, and then I think we're going to have to move on. Helen.
I just wanted to say that I organised for the comms team, all of our team, to have a session with Pete from Emily's team a couple of weeks ago. And we've got a follow-up session with them next month as well. And just to say the feedback from my team has been absolutely fantastic. Just that opportunity to talk about what a difficult year it's been. And we also invited Pippa Smith, who's one of the HR business partners. So she came along. So she was able to offer that link back into HR. So anything kind of practically that we wanted to take forward, just having Pete kind of facilitate the meeting, but Pippa there as well, from an HR team perspective, was just invaluable. So I just want to reinforce my support for the work that the team does and say it really is making a difference.
And Helen, I think as a board, we should say thank you to you and your team too, because I know you've been part of some of the initiatives. For example, memorably, the Valentine's Week.
It's a regular feature.
Love yourself, Sheila. Love yourself.
One of the things that really will stick in my mind, Emily, is the fact that, you know, that was fun. There were fun elements to that, as well as, and actually laughter's a great support, you know, and you engendered a sense of well-being in the broadest sense. There is the very professional high end of this, but there is also that warmth which makes people feel supported, you know, when times are tough. I think you probably get the message from the board. You're pushing at an open door in terms of the future of this. I don't think there are no hurdles to overcome there. But I do recognise, and we haven't got time to discuss the details of it today, but you've listed some of your challenges. And we know that accommodation is a real challenge everywhere in the trust. But, you know, practical things like that for your team, you know, we need to make sure that we can support you practically, as well as being very emotionally warm towards the service and supporting its continuation and making sure that Craig does find you the resources to make sure it keeps going. That's really important. And thank you and the team, and please pass the board's thanks back to the team, as well as our thanks to you, Emily, for all you're doing and for what you're doing in helping our managers to be better managers. Because actually, you know, even if we expand it, if we doubled your team, you are a finite number of people, but every time you work with a manager, that touches the lives of all those people in their teams, and that's really powerful, because that is really culturally changing. So thank you, Emily. It's a great report, and it really helped to have you come and you talk about real people. So thank you very much.
Thank you.
And I will now hand back to Jeremy. And have I got any questions on the rest of Jeremy's report? Jeremy, did you want to come in at that point?
Well, it was really just to categorically give the board assurance that clearly we will work with Emily and I and others will firm up our plans around the future. This isn't the end of the conversation. This is the beginning. And we'll be effective on
Jeremy, I'm having a little trouble with your sound. Are other people having trouble hearing Jeremy? I don't quite know why, but you just bear in mind, Jeremy. I'll stop you if it gets too bad.
Okay.
Okay, thank you. We'll look forward to the more detailed report or business case coming back. Okay, David, you've been waiting for a general question.
Yeah, just on the staff survey, which is obviously an annual thing. I'm just wondering whether we have in place or should have in place an internal survey where we can monitor more frequently our progress against some of the things coming out of both this survey and also the what matters to you.
Yeah, thanks, David. Hopefully you can hear me.
Yes, you're better.
Good. There's also balance to be struck around more regular data versus survey fatigue. I can tell you that there is a plan nationally for a more regular staff survey, potentially quarterly, and I'll keep you up to date with that as those plans progress. But that's certainly one of the things in the national people plan that is being taken forward, and I welcome it.
Thank you, Jeremy. Richard.
Yeah, can I just come in on the education and training report, if that's okay? Fantastic report as ever, and it's wonderful to see the range of stuff that the Trust is doing, and sort of emphasises how much this is a training and learning organisation. My question is, I know it's really hard to measure quality in training and teaching, but I wonder what data the Trust does have about the quality of what we're delivering and whether there's any scope for incorporating something about that in future reports.
Yeah, certainly the quality of what we deliver in most domains is overseen by Health Education England themselves, of course, and they conduct regular visits and undertake engagement with both trainers and trainees in order to do that. That I agree with you. There is there's a reference, for example, in this report to the HAE quality review, and we can certainly provide an update following their visit, I think, which is planned for next month. But that's, I think, something I would take away, Richard, and think about and develop for future reports.
Thank you, Jeremy.
It's a good point, Richard, and I think it relates to some of our other activities where we need to understand the quality of how it's done and not just what's done. Okay, thank you. If there are no further questions, Jeremy, thank you for your report and thank you for inviting Emily to our meeting. That was extremely powerful, but it's also quite powerful now that we have all the people's stuff together. I think that's really important. Because, you know, I often say people are our greatest resource, and they are. And sometimes in the past, it's felt that we looked after them, but in very disparate ways. By bringing all the people stuff together, it feels as if we're more focused. And I think that's a really good thing for the board. So thank you for that. And I'll now move over to quality, safety and improvement reports.
Thank you, Sheila. So we'll start off with the maternity paper, and Karen, as always, is here to give you a brief overview of the paper and take any questions. So I'll hand over to Karen.
And welcome again, Karen.
Thank you and good morning to you. Okay, so hopefully you've had a chance to read the paper. So the points that I just would like to highlight to you are regarding the Occupational report. So we had to submit our actions and whether we were in line with the recommendations in Occupational. These were then looked at from the regional perspective, and then we had our feedback this week just telling us which areas we just need to provide a little bit more evidence for. So we will be working. I feel really quite assured that we will be able to provide the majority of the evidence that they require. The only thing that was quite a surprise that we were told was that we need to have a consultant midwife, which that has never come up before. But so yes, we will be working with the region to look at funding for that. So yes, but apart from that, hopefully we will reach everything we need regarding Ockenden. In line with Ockenden, one of the things that we need to do is to make sure that we're using the perinatal clinical quality surveillance model. So that's why for this paper and forward-going papers, I will be including the safety champion feedback from the walkabout and virtual sessions, and also service user feedback as well, because it does say that the board should have oversight of what our service users are saying. So that's why I have included it for this paper. And then the only other thing that I really would like to just highlight to you is about the assurance visit that happened in February. We've had the draft report that has come back. It overall was very, very positive. I think there's 5 actions were ongoing actions from the last visit that we're just very close to finalising. So again, that was all very positive as well.
Karen, that's great news on the feedback from that walkabout. I mean, that really is, because that's your peers having a look at what you're doing, and that's always powerful.
Yes, that's good.
And the service user feedback in the middle of that presumably was collected during the COVID epidemic.
Yes, so this is every month, so that was just February, so that was really fab. That was really good. And the our Facebook page does have very, very positive stories. So with the staff survey and everything else, you can look at everything very negatively, but actually our women are very, very complimentary about the care they receive. That's brilliant.
We're about the mothers, the babies in your case, yes. Our patients, our community. So that's really powerful feedback. So I think you and the team can feel very proud of that, because that's the human element of the service, very much so. Richard, I'll hand over to you as champion.
Yeah, sorry, this is a comment and a report rather than particularly a question, and my role as maternity and neonatal safety champion. I've had some discussions with midwives, and I've spoken to Karen, and of course from the assurance visit, I know that there are ongoing staffing pressures within maternity, and I understand that they're quite complex issues. And I also understand that there's work ongoing to try and address those issues. But I just wanted to make sure that the board doesn't lose sight of the staffing pressures and the complexity of that within the midwifery service, particularly as the Trust plans to move to the proposed 100% continuity of care model. So I just wanted to raise that and highlight it. Thank you.
Thank you, Richard. And I mean, you've already alluded, Karen, to the unexpected requirement for a consultant midwife. I think the complexity of the staffing is not even continuous, it changes as time goes on. So yeah, we do appreciate that it's extremely challenging.
Thank you.
And the board is there to support if they can.
Lovely. Thank you.
Is there anything else that Karen, you wanted to highlight, or Sue, you wanted to highlight?
Yes, I just wanted to say that I had a fabulous day last Friday. I was a midwife for the day. Well, I wasn't really. I was pretending to be a midwife for the day. And I spent the morning in the theatres with a semi-emergency caesarean section, and then a caesarean section for planned twins. Both were amazing experiences, and I was hugely privileged to be there. I can't tell you. And I have offered to be a godparent to all 3 of the children, but I think they've got other plans. The twins, I just wanted to share, the twins were, the mother of the twins was being looked after by a continuity of care midwife who was in the theatre with her. She was extremely anxious and extremely frightened, and I have to say the fact that she knew the midwife knew her, and had built that fantastic relationship up through the continuity of care process was absolutely brilliant, and I'm sure made a huge difference to the woman and her husband in the while they were being delivered of the babies. So just wanted to point that out, that it is such a fantastic, and the midwife was so positive about it as well. So it was really good, and I had a lovely day. So I want to say thank you to Karen and the team.
Thank you, Sue. And I think, you brought us back again to real parents, real babies. And you know that's what we're here for. So thank you for that, Karen. Thank you for your report back. So thank you for your anecdote, which really brings it alive, and that's great. But we need to move on through your report now, Sue, please.
Yeah, thank you. Okay, so I'll bring you through to the Infection Prevention Control Assurance Framework. This is a report that you've seen month on month. I think things just to highlight this month are the fact that we have been sent some further requirements to include in our BAF, which we will work through. The other thing that we have completed this month is, and are continuing to review, is you may be aware that the Health and Safety Executive have sent through some pointers of visits that they've carried out in other organisations, and the team have, and myself have been going through that to identify any gaps in our services, so that we can be assured that should the Health and Safety Executive come in, we've learnt from other people's not problems, but we've learnt from other people and other organisations. Just to note that obviously, although the number of COVID patients are reducing in the organisation, we're still focusing, and we have still yet to complete all of the SI investigations into all of our outbreaks, but we are working through those and the duty of candour for those patients. The learning has been shared. It's been shared through the NMCC, it's been shared through the staff briefing, and we continue to use this sharing in our day-to-day conversations with all staff, and also reminding staff that while we might not have so much COVID in the organisation, that the requirements for PPE remain the same, and we mustn't let our guards down at this very crucial moment in time. I'm happy to take any questions if there's anything anyone wants to ask me.
I have none flagged, so thank you for that comprehensive report. Thank you, Sue. And we'll move then straight to nurse staffing, please.
Yeah. So Dan sent his apologies for today. I've given him a day off. I don't know why I did that, but I have. So I will present the paper. I'll take it as read. I think the things to note is that the overall trust fill rates have improved in all shifts, day and night this month. Sickness rates have improved compared to previous months. And the nursing quality indicators have improved slightly, indicating a link to fill rates and patient safety. We have received our final audit report of the safer staffing, and we have got an action plan appended to this paper. And again, there have been significantly fewer staffing incidents reported this month. What we're trying to do now is to work with the staff on refocusing and building their sort of making sure they've got their rest and making sure that they feel resilient and able to continue to work with us, and making sure our patients are receiving the good quality care. Again, I'm happy to take any questions. Just to point out that the nursing vacancies, as you will know, will change, increase next month when we build in the new posts that were agreed at the recent comprehensive staffing review. And they will be there, but we have got some mitigation in so much as we have got a ward closed for the decant and the rack plank. So we will continue to monitor staffing and work proactively with Jeremy and the team on our recruitment and retention. We've got about 20 students qualifying in September. We're starting to already recruit them, and we do have a very good retention rate of our students. So we are anticipating that we should be able to recruit as many of those as well, a high number of those. There we go.
Okay, thank you, Sue. Are there any questions for Sue on the nurse staffing report? It's pretty comprehensive, and I know people have read it in detail. Steve?
So I think it's a great report. Sue and Jeremy and me and the team, we've had this discussion. I'm just keen to get a sort of a trajectory and a plan to try and reduce our vacancies. They are going to increase, and I think we've been quite successful recently at overseas recruitment and so forth. There's something about whether that's calibrated to the gaps that we've now got, but we're going to take a look at that. So thank you.
Thank you very much indeed. Thanks, Steve. In which case, I'm going to move on seamlessly to the improvement board. And can I remind you, Sue, there was that question that was asked. So
the improvement board is held every month, and it is at that improvement board where we agree and discuss any movement of actions from complete to black, which is black or blue to business as usual, or we do have the challenge of whether we should move them back because they're not moving in the right direction. So there is a really robust oversight, and that's attended by our external colleagues as well as our internal colleagues. So and Sheila. So we do have the assurance that 75% of the musts, as stated, are within that. Whether that's an acceptable level of progress, I think what I can say is that we do have that external sort of challenge on our pace and our ability to deliver all of our actions. What we are now at a point at is that we have completed a number of the CQC must-dos, and what we're really now keen to do is to move this action plan into an overall trust improvement plan rather than it being a CQC action plan. So you will hopefully over the next couple of months see a new look action plan or improvement plan that will come through, and that will be a working document for us as an organisation, and how we continue to monitor that will be discussed at the next improvement board. We've already done that with maternity services, and the quality and safety team are now working through how we can articulate our movement from starting up PSERF, which is what we've initiated, into what are the actions that are now coming out of that we need to improve and demonstrate organisational learning. So I'm hopeful that answers the question. I'm happy if anyone has any further questions. Is Sheila on mute?
Richard, I was turning to you as the other member, the other non-executive member of the Improvement Board.
Thank you. Yes, so this is a more general question, really, and I'm aware that a lot has changed in relation to quality improvement in the Trust since it was highlighted as a priority improvement project, I think it was a couple of years ago. We've got the Improvement Programme Board, we've got PSERF, we've got changes to learning from deaths, we've got recruitment of a new Associate Director, and I was beginning to feel a bit lost, if I'm being honest, about how these things all fit together. And I thought it was just me, but talking to my NED colleagues and talking to some clinicians, there's also a sense of uncertainty about how this is beginning to fit together. And I just wondered what plans we have as a Trust to develop, update our quality improvement strategy, and more importantly, perhaps to communicate that effectively throughout the Trust.
Thank you, Richard. Good question. Sue, do you want to, shall I take the other two questioners first? Could you hold one? Nick, you wanted to come in. Can I take the other two in case they're on quality improvement?
You can. I just think the quality improvement question Richard just asked is for me rather than for Sue, but I'll wait in case that's what. I think
that's one of the reasons I was holding it. Rosemary, was it a separate question or did it relate to quality improvement?
It relates to the current discussion.
Okay, that's fine. In that case, get your question and then I'll come to Nick and to Sue.
It's just a specific point. I noticed on page 150 of Convene, where you've got the action plan, it's the first action there, it's about culture and engagement with the medical staff. It's down as closed. Is that because it's closed as a CQC action, or because, so, you know, building on Richard's point, it's quite confusing because that whole aspect of culture and communication engagement isn't sort of closed and complete, is it?
No, so Rosemary, black doesn't mean that it's closed. It means that it's completed. What we now need to do is
completed.
Yeah, so some of the actions within the action plan will have been completed. Now what we need to do is work as an organisation through Jeremy's people plan on how we now start to embed that as business as usual. So black doesn't mean to say that it's closed. It means that it's got further work to do to then become embedded as business as usual. And again, as you'll see a new look action plan or improvement plan for the quality and safety, you will also see one for the trust culture, which will feed into Jeremy's people plan.
Right, because just looking from the outside, it looks quite confusing because it looks as though the action has been done, but actually there's still an awful lot of work to do around that subject. So it is confusing from an external and outside perspective.
So it's a really good point, Rosie, and I think there's something about just being clear about, in a sense, what is the framework of how we're tracking, which is, in a sense, we've done what we've said and set out to do. The key question for us, and this is further, motivated by what we've just heard about the staff survey. The question is, we've started to do the right things, and we've done some things. Is it shifting the dial? Is it enough? Do we need to do some other things? And I think that's the reflection that we need to get into. And just because it says that we've completed these activities does not mean that we've changed the culture, as we'll come on to around thinking in terms of how we knit the story together to tell staff. That might be one of the key actions that we need to do that responds to that significant dip or concern that we've witnessed in the staff survey around staff feeling like they can speak up, and or that we're a truly listening and learning organisation. So those things, do need to progress. We need to make sure we get a different action. The question is where does it get tracked, and how do we communicate when we, in a sense, reinvigorate those actions, if that makes any sense.
And at a very simplistic level, Rosemary, you'll be pleased to know that the kind of debate about where it should sit in the ratings is a very live debate every single improvement board meeting. And, it's attended by external partners who are frequently challenging about our judgment, and it leads to some really rich debate around those topics. And I think Richard can endorse that. Nick, I will hand over to you now on quality improvement, because I know you've got some updates, and that's a really important area.
Thank you. So James McFarlane started as our Associate Director for Quality Improvement last week, and is already getting his feet under the table, and certainly in the conversations I've had with him, very definitely it is time for us to set out for the whole organisation clearly again what quality improvement is and what it does. And I think there is still, despite the significant efforts of James's predecessors, to be fair, there is still a real misunderstanding of the difference between improving quality and quality improvement, and I understand why. What James and Natasha and the team will help us embed is the science of quality improvement as something that underpins the way of working across the organisation. That is starkly different from the work, for example, of the Improvement Board, which is all about improving quality. Now, what's good news is that a lot of that work is being done using quality improvement method, and particularly the IHI method that as an alliance system you'll remember we've been investing in over the last 18 months or so. So I think there is a lot to bring together. Natasha and James in the QI team are working on how we best display that to the organisation and to you, so that we can see what's what and develop where we go on from here. But I think it's very good news that we've got James, who's started. He's not just started in the alliance role, which you might remember is what was funded, but we have also funded the remainder. So he's 0.6 in the alliance role, if you like, which obviously we have shares in effectively. But the other 0.4 of his job is working exclusively for the trust, and I think that should make a difference to our ability to share internally the QI strategy.
Thank you, that's very helpful.
You're on mute, Sheila.
Bad day, I keep touching it without meaning to. Okay, thank you, Nick, that's really helpful and very encouraging. Unless there are any other specific questions on the improvement board, then, or on the programme attached, I'm going to move on to the digital board. Craig.
Thanks, Sheila. So I'll take the report as read, and it was referred to earlier by Steve in his report. It is one of the most significant go lives that we have had in the last few years. there were nine hours of downtime to e-care that we had to manage through in order to organise the cutover. It went really well. So huge amount of effort from not only the IT team, but the team across the hospital in pharmacy and maternity in particular. So you've got the details in the paper, but I think I would consider it quite a success that we've had over the last weekend.
Thank you, Craig. And I think we'd all want to send our congratulations to the whole team, because we know that the amount of work that goes on before a going live event like that is huge. And the fact it went so smoothly is down to, I'm sure, to the preparation.
Yeah, all planning.
Absolutely. So very many congratulations to the whole team on getting that right. David.
Yeah, as an organisation, we've obviously adopted e-care and continued to develop that. As we move more to integrated care, we're probably going to have to link up with other systems around, the system. I'm just wondering how we're going to manage that more global strategy around digital. Is that something that we will take a role in, or where do we see the ICS taking a role in terms of an overall digital strategy for the new system?
So there is an ICS digital board that Steve chairs. So we do look at things from an ICS perspective. It's fair to say, and we've covered it in previous digital reports, but the work we're doing around HIE and linking up disparate systems across the NHS is probably nation leading. We're on a par with the One London system, so we're already linking up organisations so that clinicians can see records across those disparate systems, and we will look to extend that. There is a debate at the moment within ESNEFT around the replacement of their digital system, and the consideration of Cerner is present in those discussions. So it could well be that we move to some form of ICS-wide digital system, but there's a long way to go with that. But we're fully engaged in those discussions. This is not about an organisational approach. This is about an NHS-wide approach as well as a system-wide approach. It was the whole ethos behind the GDE programme, was that organisations don't exist in a vacuum and you need to be able to spread learning. So we're very committed to that.
Right, thank you.
Thank you, David. Rosemary and then Steve.
Thanks, Sheila. Craig, can I ask a question about medicine management? And I know it's not specifically digital strategy, but I think Steve commented on it in his executive summary. Can you hear me okay?
Yes, yeah.
Okay, thank you. One of the concerns raised by the CQC was the inconsistency of the trust medicine management. So with the new system, how will you ensure that the medicine system will be effective, and that it will give us the results that we want, and that it will improve the medicine control?
So Nick's probably better placed to comment on the clinical aspects of this, but obviously an electronic system like the one that we've improved over the last weekend will provide us with access to more and more data in order to compare practices. It also gives the ability to prompt within the system so that decision making is more consistent. So one of the issues over the weekend was around warfarin prescribing, so making that more consistent, coherent, comparable is one of the advantages that we get from the work that we've done over the last weekend. But Nick, is there anything you'd want to add on medicines management?
So I think it might be me and Sue, Craig, because there's two aspects to medicines management. There's the prescribing of it, which obviously is normally done by doctors or nurse specialists, and then there's the administration of it, which is normally done by nurses. Both have been improved over last weekend. Craig's already outlined the warfarin. Scanning for safety is probably the other big change. So we now, on every drug round, the nurses administering the drugs scan the patient's wristband and the box of the box containing the medicine to be administered. That's important for our HIMSS level 6 achievement, but it's also an important step forward in patient safety, I think.
Thank you, Nick. I think this is probably a question we can take offline or bring back, because it's a more complex area. I'm not ignoring it, but we can deal with that on another occasion. I've got Steve.
Thanks, Sheila. I'll be brief. I just wanted to say to David, you may not be aware, but other board members, I hope, are aware. I chair the ICS digital board, and also I'm the co-chair and sponsor of the regional, shall we say, board that oversees some of this, basically about trying to join things up. So we're taking a very active role in that space. We're not being insular, and as Craig's alluded to, the health information exchange, the work that we've been doing on getting shared records, health and care records, not just health records, health and care records, has been a cornerstone of our strategy, and shall we say, something that the IT team has delivered a real legacy on.
Thank you, Steve. Okay, if there's no more questions, thank you for that and that report. Can we move on to the Future Systems programme, Craig?
Thanks, Sheila. So again, paper is hopefully self-explanatory. Just a couple of comments. One, we continue to push around the formal acceptance of our SOC. We sent an email this week to the Department of Health to encourage them to formally assess our SOC, give details in the paper around the informal feedback that we've had and the work that is ongoing. And the only other point I'd want to make is you've got an appendix to the report that went to the programme board, so a number of you will have seen it before, but I think what it does is illustrates the work that's going on within the Future System programme, and hopefully gives some idea of the legacy that will be left in terms of the leadership capability that we are creating within the organisation. So as part of the Future System programme, there is a huge investment in individuals across the organisation and the leadership roles that they are taking. And you've got some details within the report. So again, it's about making sure that everything that we do across the organisation is coherent and focuses around some of the messages we've had, both from the CQC report, the What Matters to You survey, the importance of line management, the importance of leadership. This is just an illustration of how the Future System programme is playing its part in that agenda.
Thank you, Craig, and I think that join up is really powerful, and thank you for that report, and it's a very, very good. I'm going to move us on at pace because time is moving on. And Richard, can I bring it to your governance report now, please?
Thank you. Yes, Sheila. I'll take the report as read. There's a couple of points I'd like to mention before looking at the recommendations, if that's okay. First of all, just a piece of work that we are going to undertake at the moment is to review our membership area as set out in our constitution. That just to look at the wider geography of the services that we provide and the catchment that uptake those services. So with the board's approval, I'd like to take the proposal to scrutiny committee for it to consider and approve those. So if the board is happy to delegate authority for that, we'll clearly also be working with the governors on any changes that we make.
Thank you. Are you happy to approve that to go to scrutiny committee with delegated responsibility? And obviously we will fully engage the governors in any other conversations.
Yeah.
And then you have a couple of items for approval on this report. You have the quality report for 1920, which seems a little historic now. Are you happy to approve? I'm not seeing any hands up to object. And are you happy to approve the proposed approach to a well-led development review? I'll take that as yes. Okay, thank you, Richard. If there's nothing else you want to add, thank you very much indeed, Richard. In which case, we can now move to our items of any other business. I haven't been brought any. Is there anybody who's discovered something extremely pressing they need to bring to the board? No, thank you very much indeed then. Note the date of the meeting. Unfortunately, I suspect it will be this way rather than in the flesh. I will then move to the closed session and I will see the board back in a little while's time. Can I thank those of you who have attended, both the public out there who are watching on YouTube, who we can't unfortunately see, but also to the governors who I know are with us this morning. Thank you very much indeed, and a good morning's work. Thank you. I will see some of you a little later.
Thank you.
Thanks, everyone.